Welcome, everyone. If we could take a seat, we're jumping right into our next session, which happens to be on perioperative care, which is enhanced recovery after surgery. We want to jump right in because we have lots of stuff, and everybody is running over on these sessions, as you can see. But exciting stuff, great talks today coming up on perioperative care. I'd like the speakers probably to stay in the audience until they give their talk, and then we'll have them stay up here on the podium for questions. So. Let me introduce my co-moderator. I'm Dan Engelman. I'm a cardiac surgeon from Springfield, Massachusetts. I'm the president of the ERAS Cardiac Society.
Hi, I'm Christoph Kirov. I'm a cardiac surgeon from Vienna, Germany. And nice to co-moderate this session with Daniel Engelman.
Welcome. So why don't we kick this off right away with Dr. Reddy coming up here to give his first talk on enhanced recovery for the sternotomy mid-cab patient. Thank you, Dr. Reddy.
Dan, thank you. Thank you to the moderators and the Congress for this opportunity. Just by show of hands, how many of you all have an enhanced recovery program underway at your facility? Certainly Michael does. Good. A little bit more than at the lunch presentation I gave. These are my conflicts. I think really we should all think about what is the value proposition of cardiac ERAS, and it's really that it's an optimization, an enhancement, and an improvement in a patient's surgical journey. And it's really many components of perioperative care that create that. I think it sometimes can be deceptively simple, and it surely can be, but it really does take a lot of implementation, adherence, a continuous improvement process, and then monitoring really to create the very best results. I think there are a lot of components to an ERAS program. Many of these are challenging to implement because of the multidisciplinary nature of it. So it's like getting a lot of people on board. Herding cats sometimes is an analogy. And I think there are challenges to implementation of an ERAS program. A study was done by Pearsall that was published back in 2015, looking out of the University of Toronto, looking at general surgeons, anesthesiologists. And what they found is that the challenges can occur in different areas, whether it's nurses that can be both an enabler, because they're the ones who do amazing jobs with education for family and patients, but they can also be barriers. As we all know, there's a labor shortage for nurses, and we really can be a burden to them because they may view ERAS as a creation of even more work. For surgeons, they can certainly be enablers and champions. I think they like to implement many of these, certainly when they're evidence-based or if they standardize care. But on the other hand, there are a lot of surgeons who are curmudgeonly. They are prejudiced against any change in practice, and they're very resistant. And certainly it's the same case whether it's anesthesiologists or any of our other allied health colleagues. But the good news is much of ERAS can be very low cost, particularly in our cardiac arena. So we can both be cheap and effective, and there are therapies that probably fit any of your service lines budgets. And it's what catches the attention of the C-suite, because really when you talk about a value proposition, ERAS cardiac is high value care. It's high quality care and doesn't always have to be high cost care. Now, when you implement an ERAS program, you should talk about what are your goals and what are your success metrics. If you look at whether you want to break it down into primary or secondary outcomes, look at where you may be performing under the benchmark, whether it's you have longer ventilation times, are your infection rates high, are you taking patients back for bleeding more often because of blood management issues? Is there atrial fibrillation, renal failure? Do you having sternotomy breakdowns? Look at all of those in addition to things that may interest some of your administrators, such as lengths of stay, readmission rates, and costs in terms of complication rates and hospital-acquired conditions. So what does enhanced recovery really look like? It's a pathway, and that pathway encompasses both the preoperative, the intraoperative, and postoperative time periods. And there are various interventions that can be made during each of those times. And it really is irrelevant whether the patient is an outpatient. You can put all of this in place for the outpatient, or you can put it in place for the inpatient. You do have to adjust your pathways of care depending on where you're encountering your patients and how to implement all of these. I think it's also very important to focus on intraoperative management and the way that's done and partner with your anesthesia colleagues as well as the intensivists, and understand what goal-directed therapy should look like and when you want to initiate it. Certainly there are very common things that occur, whether your patients are sternotomy patients, minimally invasive patients, whether they're CABG only or CABG combined with other procedures, but simple things like preventing in addressing nausea and vomiting, addressing the way you want to take care of pain, your approach is that all of these have to be thought out and then planned and where you want to implement them. One of the important things that we know about is goal-directed therapies, one of the mainstays or hallmarks of enhanced recovery, because we know that overhydration and dehydration can both be detrimental to patient outcomes, and that really achieving an optimal balance of this with a variety of techniques, whether you want to use non-invasive techniques or invasive techniques, that this is very critical to how patients do afterwards. So goal-directed therapy can have different protocols. This is an example of one that we use at our center, but whichever protocol you use, make sure you're really reaching the end goal of appropriate tissue oxygenation and delivery of perfusion to the tissues. I think another important component is our DREAM goals. We talk about early oral nutrition. This could be very dogma related, but I think it's important to implement all of these. And there will be very simple low-cost things like just chewing gum or hard candy have been remarkable in our own center in just decreasing the rates of ileus that we see. Certainly early mobilization is very important, and that you have to encompass and incorporate your team members from physical therapy, occupational therapy, and certainly your floor nurses in doing this. And it's important to do this as early as possible and reach those milestones. A part that's often overlooked is patient education. And nowadays with so many, whether it's app-based, like our entire program for this meeting itself, whether it's based on an app, whether you want to do it web-based, whether you want to use a QR code and let them scan it, as we do at our center, I think it's very important that patients receive education not only before their operation, but during various periods of their recovery, as well as after discharge. And you can still do old-fashioned things like give them a brochure. That's okay as well. And we started with that, and we've really shifted more to multimedia-based. I think another important thing is to create checklists that the patient is engaged in marking off themselves. And whether you put it as a board in the actual patient's room, whether you give it to them in an electronic format, you must incorporate a patient's recovery by milestones that they feel like they're reaching and then performing and documenting. So I guess the recommendations, to summarize in a way, is that implementation is the key. What I challenge each of you in this room is to do something when you leave. There's a lot of pre-work you have to do. You have to involve stakeholders. You have to get buy-in. You have to actually champion this. I think one of the resources I would go back to administrators for is a type of nurse navigator or an internal champion. You simply can't do this while you're in the operating room or your intensive care unit. You have to get someone outside of that arena to be helping kind of coordinate and collate all of this. Certainly expect the unexpected, everything from the drinks don't show up in the places they should, machines don't work, medication deviations, but if you stick with it, and I think if you constantly fine-tune it, you'll be celebrating your success sooner than you realize, and you'll see a change in those metrics. As you saw earlier today, these type of patients, no matter how complex they are, whether they have temporary mechanical support, all of them can benefit from them. And as I pointed out earlier today, you really get patients smiling when you implement ERAS, because I think at the end of the day, it really is the right thing and the best thing for patients and their families. So adjust your sails and look to the future. Thank you very much.
Thank you very much. I think we'll continue straight in the interest of time. Next speaker is Joseph Sabick from the Cleveland Clinic. I think he needs no further introduction.
Good afternoon, everyone. It's a real pleasure, obviously, to be here. If I could just get my slides to move. Oh, here we go. These are my disclosures. Now, it's an interesting topic, beyond STS preoperative risk assessment. I think we're all very familiar with this type of a risk assessment, whether we've used the STS predicted risk of morbidity and mortality. The Parsonet score, some of you may remember, was very popular when I first started practicing. There's the logistic Euro score, as well as the ASEF score. And as you know, the STS has come out with a new risk model, and it's actually really easy to use. If you haven't had a chance to try it, I would encourage you to go to the link. I was actually hoping I could do a demonstration right from here, but it turns out I don't have web access, so I just added some slides. If you were to, click that little site, this will come up. And what's really cool is that as you kind of put in your patient's characteristics, over on the right-hand side of the slide will come up that patient's risk. So here you can see this morning I just kind of added a bunch of characteristics of a pretty standard patient having first-time coronary surgery, and you can see over to the right hand what their risk of mortality is, as well as morbidity, and a little clinical summary. And you can also hit a little box at the end, which is a PDF summary, and you can actually give this to your patient, when you explain their risk. And for the vast majority of our patients, this is really all we need to do. But I think, all of us would say that the practice of cardiac surgery is changing. And we're all seeing a lot of elderly patients. And although that these risk calculators, work well for the majority of patients, I think when we start looking at our elderly patients who are frail, who have disabilities, these things really aren't taken into consideration. And obviously, we want to make sure we do the right thing. We don't want to take somebody to surgery who's not going to recover. So we want to have a good idea of what their risk is. And I thought what we would talk a little bit about today is how these studies and which studies you might want to use can add on to your preoperative assessment so you can decide whether this is an appropriate risk for the patient that you're about to operate on. Frailty is defined as a geriatric syndrome of impaired resiliency to stressors, such as cardiac surgery. And disability is defined as an impaired ability to carry out functional tasks. Now, many of you are probably saying, well, these things overlap, don't they? And they absolutely do. A frail, disabled person's most likely going to have many comorbidities. So the question is, are they really additive? And there are many different types of tests that you can use to look at frailty and disability. Obviously, some of them are activity measurements, and other ones are questionnaires. Some of them can be very long and extensive and difficult to do, and others, very simple. These are just some of the more common frailty scales. I think everyone is probably familiar with the concept of a 5-meter gait speed. There's something called the Cardiovascular Health Study Frailty Scale, and it has 5 or 7 items that can be evaluated, such as gait speed, hand grip strength, inactivity, exhaustion, weight loss, plus or minus cognitive impairment, as well as depressed mood. There's also the MacArthur study of successful aging, and you start to see this. There's a lot of tests that are measures of activity as well as a survey. The most common, again, is the 5-meter gait speed test, probably because it's the easiest to do. And as it sounds like, what you do is you have your patient walk 5 meters, and you measure how long it takes for them to do that, and you do it 3 times, and you take the average. And if it takes them longer than 6 seconds, they are considered frail. There are all sorts of different scales when it also comes to evaluating disability, and the one that's probably most popular is the Nagy Disability Scale, and you can see the different requirements for that. Now, this was a very nice study that looked at, could we improve our predictive ability by adding both measures of frailty and disability to a comorbidity scale, and which ones would be valuable. And they looked at many frailty scales, many risk scores, as well as disability scales. And they found that gait speed alone was the most predictive and valuable. And when they looked at disability scales, the Nagy, and then when they looked at risk scores, it was both the STS predicted risk of mortality and morbidity, as well as the Parsonet score, which again is a very old measure that I don't think is used too often, but you can correct me on that. They also then, and this was a very old STS risk meter, probably from around 2012, but they actually found that putting together the 5-meter gait speed and the Parsonet score and the Nagy scale gave you the best predictive value. It was a little bit lower if you switched the Parsonet for the STS prom. I wonder what it would be like with the most recent study. And the other thing I think we want to think about is our nutritional status of our patients. This is very important, in particular in their ability to respond, well after cardiac surgery. Just like there are many studies, scales for frailty and disability, there are several different measures that you can use for nutritional scales. And essentially, it's kind of a series of questions. Has your patient lost weight? Have they gained weight? What's their BMI? Things like that. What's happened, recently? And you can come up with kind of how they're doing nutritionally. And they looked at how these different studies were associated with postoperative outcomes, particularly morbidity and mortality. And they found that nutrition was, as we expect, extremely important, and that both the MUST scale and the MNA scale were very predictive on how patients will do. So in summary, for the vast majority of our patients, just comorbidity risk scores, such as the STS predicted risk of mortality and morbidity, is appropriate. But today, as we continue to operate on older and more elderly patients, we need to kind of expand our evaluation a little bit, including measures of fragility, disability, and nutritional status to get an accurate measure of that patient's risk. Thank you very much.
Thank you, Dr. Sabik. Our next speaker, also from University Hospitals, Dr. Rakesh Arora, and he's going to discuss how once Dr. Sabik identifies that his pre-op patient is frail, can he actually do anything about it before surgery?
Thank you very much for the opportunity to present today. It's always a little hard to follow one of your bosses, but I'll do my best here. So I'm going to build upon the themes you've heard from Sinu and Joe already and provide a bit more practical implementation tips, perhaps, for your teams to consider. These are my disclosures that have no direct interaction with this talk, and I'll be talking about nutrition, but not any specific product per se. So if you leave with nothing else after this talk are these three things that you've heard a little bit about already. Look for frailty in your patients using a routine tool, and I'll show you a couple of examples of what you can use in your practice, and specifically what our cardiology colleagues are trying to use. Start with early wins. When you're talking about ERAS, there's a lot of different components of this. Nutrition is one of the lower hanging fruit you've heard both from Sinu and from Joe, and I'll reemphasize that as well. And then prehab for cardiac surgery patients, which may seem an anathema to give people an exercise program with uncorrected cardiac disease, specifically those with coronary disease. I'll provide some data to show that it's of benefit and safe for your patients. So these are the guidelines you're likely familiar with when we're referring to the ERAS cardiac surgery documents of a 22-point step plan that is divided into preoperative, intraoperative, and postoperative components. And for most of us mere mortals who don't have a navigator or a really dedicated team, this can look very hard. And where does one start? So where we have focused a lot on the postoperative phase in our care for cardiac surgery over the last several years, I'm going to focus a little bit on the preoperative phase for you today. So as we heard about, frailty is really a biopsychosocial paradigm. I'm going to focus a little bit on the muscle component or the sarcopenia component that's contained within this umbrella term that we call frailty. If you look for frailty in your patients, about 50% of them will be frail using any one of the tools that Joe has just shown you in the previous slide. And why that matters, if your patient does have frailty, they have a 5-fold increased risk of major adverse cardiovascular or cerebrovascular events. So it's important to identify those patients, and then more importantly, to find means to optimize them for their surgery. So looking for it first, this is the clinical frailty scale. This was developed initially by Ken Rockwood from Dalhousie University, looking at 65,000 older adult patients, and determined a large scale of things that can go wrong with people called the frailty index. He's then simplified this for something called the clinical frailty scale that divides it up into discrete categories that provide some objective criteria to the eyeball test. Our cardiologists are now starting to use this as more routine in their practice. This is the official document from the ACC, and so you may hear your cardiology colleagues talking about this, and it's actually a pretty good broad net to look for frailty in our patients. It's probably not the most specific, but relatively sensitive for our patients. Jonathan Affolalo, a cardiologist from McGill University, again discussed in the previous talk, has really been a thought leader for us in this frailty in cardiac surgery patients. Through the frailty AVR study, which had looked at a bunch of different frailty assessment tools in the setting of those undergoing either SAVR or TAVR, we developed this sort of 3 or 4 point plan to identify risks in your patients called the Essential Frailty Tool Set that looks at some features of sarcopenia, so the chair to rise test, looking for cognitive impairment, baseline lab values of hemoglobin, and albumin. And with that, there's a tool that you can use. I have no specific financial interest in this, but you can download this for your phone and use it in your clinic tomorrow. And it's very easy. It gives you a little tool to do a 3-word recall with your patients. It does a chair to rise test with a little timer, and then it gives you a score. And less unhappy faces is better. If there's a lot of unhappy faces, you may want to consider what you're going to do with that patient before you take him to the operating room. This has just come out last month, somewhat out of the blue. I wasn't aware this was coming, and I'm pretty deeply immersed in the frailty world. This is from the European group, where they've put together a very comprehensive document of the various frailty testing one can do in both coronary surgery as well as non-coronary surgery. It's perhaps a bit too complex, and I think this is really for the 201 groups out there who are really looking to refine their processes. I'd suggest what the ACC has suggested for us to do with a simple frailty scale is probably the way to start, and you can build upon that with these other tools that I'm referring to. Okay, so you now identified a patient who's frail. What do you do about it? This could be an hour-long talk in itself, so I'm going to focus really just on the optimization point as it pertains to nutrition and a little bit on exercise. So the first thing I'd suggest you take away from this talk is that every patient can be an ERAS patient until proven otherwise. When I first came to the university hospitals a year ago, selected patients were being used into an ERAS pathway, and we kind of flipped the script a little bit and said everyone's going to be an ERAS patient as an opt-out rather than an opt-in sort of format. So when we're booking our patients, they're an ERAS patient to start with. What that means is they get this kit that gets mailed out to their home. There's some preoperative nutrition that are meant to start 7 to 10 days prior to their surgery. They get little exercise bands, an incentive spirometer to do the respiratory training, a little QR code and a booklet they can scan that takes them to a website that has a bunch of different patient education materials and exercises they can do, and the carbohydrate loading as well. So the carbohydrate refers to getting this complex maltodextran-like solution the night before surgery, where you get 100 grams divided in 2 doses, one at dinner time and one just prior to going to sleep, and take the 3rd dose en route to the hospital in the morning. So really reducing that NPO time from being nothing after midnight to allow them to drink clear fluids to 2 hours up prior to their operation. And while this may seem antithetical to those patients with diabetes, it's actually been shown to have improvements in insulin resistance, improvement in glucose control, and a return of gut function postoperatively. So this is our own data. You can see back in January, before we started this program, about 5% of our patients were ERAS patients. When we flipped the script, now we have about a 70 to 80% compliance of ERAS eligible patients going through an ERAS pathway. I can now, through Epic that we just converted to a month and a half ago, tell you which surgeons is compliant and which ones are not, so I can target their clinics preoperatively to see how we can improve their enrollment in our patients. So in addition to nutrition, exercise is something that in centers like in Canada and other areas where their wait list is probably a bit more practical. There have been a few RCTs, though not many, some of them quite old, that have looked at the safety and efficacy of these of doing preoperative exercise. These are 2 of the older ones. One's almost 24 years old now, from Heather Arthur's group in McMaster, that showed in patients with coronary artery disease, if you put them through a dedicated cardiac rehab program before the operation, they had improvements in both the mental and physical scores. This is the bottom one's one we had done as a pilot study a few years ago, where there was an improvement in your 6-minute walk test as well as your gait speed analysis. A more recent study from the group in the UK did not find the same results, so I think there's still some opportunities to learn more of how exercise can be used in our patients preoperatively. But at the very least, in all these studies, it seems to be safe. There aren't increased rates of coronary events or urgent admissions to hospital in those patients undergoing an exercise program before their operation. What do you do about inpatients? So we're not yet doing this at UH, but in my previous institution in Winnipeg, we were doing an exercise program whilst people were in hospital based on symptoms. We coordinated this with the bedside team, the PTs, as well as our exercise physiologists in the hospital, and then we go through a dedicated program while waiting for surgery in hospital. How does it apply to a lot of what we talked about yesterday and today for the minimally invasive patient? There is benefits now showing for even those with minimally invasive surgery in terms of reduction of length of stay, blood loss, time to ambulation, and increased patient satisfaction, most importantly. So while the ERAS pathways can look very complex, and to some degree they are, a lot of it's probably what you're already doing very well and requires a little bit of tweaking or modification. Some of it may be new. Start with the early wins with your team. I think make every patient an ERAS patient until you can prove otherwise, and look for opportunities to optimize them to the best of your ability. With that, I'll stop, and thanks very much.
Thank you very much. We'll skip the panel discussion for the end, and I'll announce the next speaker. This is Michael Grant from Johns Hopkins.
So thanks very much for allowing me the opportunity to speak today. So this is obviously a topic that entire conferences are based on, so I appreciate the 8 minutes I was given to talk on it today.
Now you only have 7 minutes and 50 seconds.
So what I felt was probably prudent for the group was to be able to leave with kind of 5 major targets that an anesthesiologist kind of performs in a given operating room. So they're listed here, and we'll go through them in an itemized fashion. So we'll start first with this notion of a balanced anesthetic. If I had given this talk about 10, 15 years ago, there would be a raging debate over whether or not you wanted to use total intravenous anesthesia or inhaled agent. And then there was a recent study that came out by Landoni's group in 2019 that put this to bed. Basically said the actual maintenance anesthetic itself is not really what kind of moves the needle. There's no mortality benefit to what you choose. So instead, what we've started to realize over the last several years, or maybe I should say investigate more in earnest, is the use of what we call complementary infusions. Things like dexmedetomidine, ketamine, lidocaine, opportunities for you to balance your anesthetic, not rely upon a single dose of any major anesthetic for maintenance. And you're gonna ask yourself, well, why would I do that? And the reason I might do that is because the second pillar of the anesthesiology world is to start thinking about pain management and opioid stewardship. The idea that historically we used quite a lot of opioids being the backbone of the anesthetic that we did for all of our cardiac anesthesia procedures. And instead, what we started to look at are alternatives to opioids, things that are multimodal in nature, but may act in a synergistic fashion to help to minimize your opioid burden and then augment your anesthetic. And listed here is a really nice outline recently published that showed a number of different interactions between various agents that are available to us, both in the operating room and leading up to the operating room, that can balance your anesthetic all the more. Our group recently, the ERAS Cardiac Society, joined forces with the Perioperative Quality Initiative and came together and really looked at the literature in this regard and came up with what we thought might be a reasonable platform for pain management. This is an outline here which shows a number of the various multimodal agents available at your disposal that are both in the operating room and then can be shifted into the postoperative phase as well to balance that anesthetic. And notably, opioids are at the end of the list. You want to use these in a complementary fashion. You should use them when they're breakthrough requirements for pain, but not as the backbone of your anesthetic. Part and parcel to this is to think about the increased application of something known as regional analgesia, the opportunity for us to think about local anesthetic through a needle in the various sites of entry, allowing us to kind of look at incisions and use those various additive techniques to reduce your opioid burden. What this also does is it reduces your absolute anesthetic requirements if done pre-incisionally. But our job doesn't stop there, obviously. So beyond the anesthetic itself, we're probably the biggest proponents of hemodynamic monitoring in the operating room. Traditionally, this has been done through the PA catheter. One of the issues with the PA catheter is recent guidance has actually shown that perhaps it doesn't have the same impact that we had hoped that it would. Patients, especially low-risk patients undergoing straightforward procedures, actually just have increased interventions, but not necessarily better outcomes when using PA catheters. But commensurate with that, what we have seen is an increased and more ubiquitous use of transesophageal echocardiography. This is obviously something that we've grown accustomed to even for our straightforward cabbages. And the reason for that is because what we now know about transesophageal echo is that it can provide us the opportunity to calculate any of the parameters you might get from a PA catheter, do them in real time, and then apply them to the patient. And what we've found more recently is based upon an STS, 1.3 million patients in the STS registry, is that the use of a TEE probe, even in straightforward cabbage, isolated cabbage, reduces the absolute mortality risk to that patient, particularly for moderate or high-risk patients undergoing surgery. But we can go even farther. These are obviously quite invasive technologies, pulmonary artery catheters, transesophageal echocardiography, but we have at our disposal a whole array of various hemodynamic monitoring devices, including most notably pulse contour analysis. There's a whole host of different trade names that are applied to this that have a range of invasiveness that can be applied to the patient. And what this does is it leverages this opportunity to look at Starling's curve and utilize proprietary algorithms to identify whether a patient is somebody who's responsive to certain fluid boluses, whether they are more responsive to things like vasopressors or inotropes. And what this can set up is the fourth pillar, the idea that we are trying to optimize organ perfusion. And through using some of these background technologies or any hemodynamic monitoring that you have at your disposal, you can set up algorithms to either improve patients' overall hemodynamics through a combination of fluids, vasoconstrictors, or inotropes. And what's quite interesting about this is that we've shown more recently that several randomized trials have supported the use of these algorithms as opportunities to reduce overall organ complications. This is a really interesting study, it's small, but what it showed was that patients who even have low baseline EFs can actually be optimized in the setting of one of these protocols, reduce their absolute organ injury, and reduce their overall risk of low cardiac output syndrome postoperatively. And this is despite the fact that they get more fluid than their counterparts, which is a little bit antithetical to what we would think would be the goals of treating that patient population. And then lastly, I'll mention, of course, that we need to be thinking about lung protection in all of our patients. This is kind of the set it and forget it mode in the operating room typically. But as people obviously understand, if you excessively ventilate or underventilate patients, you can get into areas that induce volume trauma, barotrauma, or atalic trauma. And a recent meta-analysis that was published actually showed that if you stay within a certain tidal volume, that is the 6 to 8 per kilo tidal volume of goal, then you actually reduce the absolute risk of injury to those patients, both in the operating room and postoperatively. But what does this all look like if you put it all together? These are all the individual pillars, but what happens if you create a program that adds it all up? Our group recently did this, published the results several years ago, and what we showed was it takes some time. These are the individual process measures that I just outlined over the 9-month time frame that we installed this package. It took us a long time to get there. But when you invest in it, you start to see gains that come from that. On the left-hand side, you'll see that our absolute requirement of opioids in the operating room was significantly reduced over that 9-month time frame. We went from about 1,000 mics of fentanyl at the outset of that particular time frame to less than 150 mics of fentanyl at the end. At our institution, we use less fentanyl for our open cardiac cases than we do for people who are getting outpatient cystoscopy. In addition, our patients are increasingly extubated both in the operating room and within the first 6 hours after their surgery. And perhaps the most impactful of all, our patients that have high compliance with all of these individual measures actually have about a 24-hour reduction in length of stay, simply from what we do in the operating room. And the idea there being that if you can set somebody up for the next milestone as they're coming out of the operating room, then those benefits trickle down the line all the way until the time of discharge. And so with that, I'll remind you of the 5 major pillars of cardiac anesthesia, and remind everybody, of course, that even if the surgery itself lacks a clear indication, the anesthetic always does. Thank you.
Dr. Grant, if you could join us up here on the stage after speaking. Yes, our next speaker is Dr. Alan Hamden, who's going to talk about medicine and nutrition in relation to coronary artery patients. We're doing a great job in the operating room. Let's see if there's more we can possibly do regarding their metabolic health outside of the operating room. Thank you.
Thanks, Dan. Thank you to the Society for the honor of speaking, especially as an interloping vascular surgeon. I think as surgeons, we're very focused on the preoperative, intraoperative, and postoperative outcomes, but I think it's time that we look a little bit deeper. So from a 1.0 perspective, this is often what a vascular surgeon might do in their office and think about. Looking about whether the patient's smoking, whether they're on an aspirin, a statin, diabetes control maybe, thinking about nutrition, looking maybe at blood pressure. For us, vascular surgeons, the disease process that has sort of the worst results over a 5-year time period is critical limb ischemia. So even though we have gone very hard at trying to do what most people refer to as optimal medical therapy, which is really just turns out to be statins and aspirin, the 5-year survival is anywhere from 30 to 50%. So that is pretty horrible, even with quote, medical therapy. As far as lipids, we aren't even measuring or talking about the right molecules. Cholesterol is needed for all to survive, and the number is really irrelevant. LDL is just a calculation and doesn't tell the story. It's really about the stickiness and oxidation. These are the measures that we should be using, and interestingly, I had labs drawn recently, and my primary care doctor said, I don't know how to interpret them. So we're quite a bit behind. So the key measures here are the ApoB, the different lower density lipoproteins from a stickiness standpoint, and I'll talk a little bit about the triglyceride HDL ratio. I think everyone in the room knows a lot about lipid management. We have a lot of levers to pull. We used to have one. As you know, statins will decrease synthesis and increase metabolism. Zetia is great for blocking cholesterol absorption. I'll talk a little bit more about that. Bempedoic acid's an interesting molecule. I'll kind of skip for the interest of time. Fibrates for triglyceride management, and then PCSK9 inhibitors, which are extremely effective, can be used in concert with statins or in place of statins, especially people who are not responding or who are intolerant. So the omega-3s and 6s are both critical. A healthy balance should be about 1 to 4 to 1 in the 6 to 3 range. The average American now is well over 20 to 1. That's because 30% of total calories are from processed healthy vegetable oils, which are actually not even vegetable oils. So what should we be counseling our patients on? Extra virgin olive oil, avocado, salmon, etc. Every processed food has seed oil in it, and telling patients to avoid, quote, healthy dressings that they get when they eat their salads because they're all seed oils. So interesting glucose basics. In a 150-pound man or woman, you only have 80 calories of glucose in your blood at any one time. You can see how many calories you have in glycogen, in muscles, and liver. However, if you're like the typical 20% body fat plus person in the United States, you have 33 pounds or 135,000 calories of triglycerides. So normal glycemic insulin resistance, I think this is really the future. So I hate the terminology of diabetes, prediabetes, and pre-prediabetes. An A1C of 5.6 is technically normal, but it's not the same as an A1C of 5.1, just like for me, an ankle brachial index of 0.8 is not the same as 1.2. A glucose of 70 to 85 should be preferred. Insulin resistance is key, as is the magnitude. The easiest measure is the HOMA-IR. All you need to do to get that is a fasting insulin and glucose. Very few practitioners actually know this or use it. The easiest way to get around that is to just do a ratio, which is of your triglyceride to HDL. It's ineffective to talk to a patient who has an A1C of 6.1, who I'm about to operate, and say, you really should lose some weight, try to exercise more. When I say normal glycemic insulin resistance, it's really not normal glycemic, it's just not that high. So some of the things people are talking about is earlier use of metformin, continuous glucose monitors in pre-diabetics, even though I don't like that term, but in patients who are insulin resistant but who are not diagnosed yet. So this is an interesting study, and basically what it shows is your biologic age dramatically increases as your insulin resistance increases. The triglyceride HDL ratio is actually pretty well established, and basically what this slide shows is if you're in the highest tercile of ratio, meaning your insulin resistance, whether you're diabetic or non-diabetic, your survival rate significantly decreases. This is a little bit difficult to interpret without a lot of time, but basically what this shows is metabolic syndrome in this study is determined by an elevated triglyceride to HDL ratio. If you actually have no insulin resistance, meaning you have a low ratio, and you have high LDL, you actually have an extremely low mortality rate. If the reverse is true, if you have high insulin resistance and an even, quote, normal LDL, your survival rate is significantly decreased. So as far as nutrition, all calories being equal is a theory that needs to be debunked. True thermodynamic in a vacuum, not if you consider the effect of macronutrients on hormones, insulin, and glucose. Ketogenesis is not a fad and has been shown in multiple disease states as positive. Key to help with your patients is decreasing carbohydrates and increasing proteins and healthy fats. It's not just bacon and eggs. There are multiple healthy pathways, low carb, vegetarian, others. Cycling diets are also helpful. For the interest of time, I'll skip some of this about mTOR and IGF-1. Interestingly, as your liver accumulates extra fat, it becomes increasingly less sensitive to insulin. It thus releases additional glucose into your blood when it shouldn't, triggering your pancreas to release even more insulin. And that's the cycle. Eventually, fat infiltrates muscle. Those high insulin levels lead to that fat storage as triglyceride, and the cycle continues. Your patients will never be able to burn fat regardless of calorie restriction or exercise. If you look at energy balance, meaning more calories in, more calories out, alone, and don't look at carbohydrate insulin, you'll never help your patients. However, if you can help your patients lower their insulin by fasting, keto, or just decreasing carbohydrates, bad carbohydrates, seed oils, ultra-processed food, you can start to allow them to have some metabolic flexibility, which means burning ketones. Blood pressure may be the most important lever we have to pull with our patients, but for the interest of this talk, I won't go into it very deeply. But remember that the metabolic syndrome is part of it is having high blood pressure, and if you help patients with their metabolism, you can help cure their hypertension. Exercise, as one of our speakers was just talking about, is critical. It's not really for weight loss. It's for these things mentioned, such as cardiorespiratory fitness and avoiding sarcopenia. The new drugs, the GLP-1s, SGLTs, are incredibly effective. Multiple studies have showed reductions in MACE and other outcomes such as heart failure. There's now evidence-based recommendations to reduce cardiovascular risk in patients with diabetes independent of the need for additional glucose control. The FLOW trial just got stopped, and that basically showed that GLP-1s stopped progression of CKD unrelated to just diabetes. This trial just come out. I'm a couple minutes over, but I think we're in decent time. The SELECT trial, which looked at semaglutide, which is a GLP-1, in patients with obesity without diabetes. I would argue that this is a trial of patients who really are going to have diabetes. And in fact, 70% of the participants who were on the placebo became diabetic within the frame of the trial. And what this showed is a significant decrease in the primary cardiovascular event, which is MACE. You can see at basically the top line from 6.5% to 8%, which was highly statistically significant. The other thing that patients need help with is they have this idea of genetics as fatalism. My father was overweight, my mother was overweight, et cetera. It's really not true. If you look at studies of twins who don't live together and married couples are more likely to have similar weight patterns than twins who live separately. It's probably 30% of baseline metabolic health. That's it, 30%. Meaning epigenetics is the key. That's the rest of the 70%. That's the most powerful lever we can help our patients with. This, unfortunately, I think is pretty typical of our medical system. And even though I'm talking about medications is important, we want to get that back to the basics. I think a good mantra is the 80-20, which is what's the easiest, most basic things you can get 80% of your required benefit. Starting with lifestyle modifications and a 3-month visit's not going to help. Starting one medication alone may not be enough. So I'm arguing for a multifaceted approach. Unless you really counsel and expect lifestyle changes, do not wait. It's fine to help start the patients on more than one med at a time. I think of the two new drug classes as a metabolic switch and reset, not something that necessarily has to be long-term. It will be long-term if they do not make dietary and exercise changes. You're already way ahead of us. As vascular surgeons, we do have some ERAS protocols, but you have a much more extensive. But nutritionists pre and post, and not just post for a week, long-term, is going to be critical. But as the surgeon, you have to engage with them at least on some level or they won't do it. Treating metabolic dysfunction as the whole disease and not just individual disease, diabetes here, blood pressure here. Early and aggressive management of insulin resistance in those not diagnosed with diabetes. More combination use of statins with Zetia. This allows you to decrease the dose of the statin, which decreases the risk of converting to type 2 diabetes. And then future, I think, is there's going to be short-term use of GLP-1s and SGLT2s in peri-procedure, often to decrease a lot of the complications, including AKI. So I'm trying to be 3.0. I'm not there yet. We want to help the patients win the 70, meaning their epigenetics. Talk to the patients, think about states of health and not absence of divine disease. And I'm actively advocating with my primary endocrinologists and cardiology colleagues to get patients on the appropriate medications. Thanks for your time. Sorry I went over.
Thank you so much. Next topic is sternotomy without mobility restriction. Speaker is Mark Gerdish from Indianapolis, and then we'll follow up with panel discussion.
Hi, good afternoon. That was a really good talk, and I want those slides.
Sure. I have my real deck.
It's a great dive, yeah. There's a lot more to be had there, right? So mine's a little bit simpler, kind of fun. I'm not going to talk too much about this. Most people have seen these papers. We did do a randomized control study. We did show all this really great stuff, and it did almost nothing. Because nationally, only about 5% of the people in the country are getting their sternums put together with rigid fixation. We do 100% in our program, our entire program. If you have a sternotomy, your bone gets put back together with plates and screws. But as a nation, we haven't moved much, even with a randomized control study. But, like, speaking of which, why do we do a lima? Why do we do multiple arterial grafts? Why do we do a Cox maze? Why do we repair type 3 via mitral regurgitation? Why do we do minimally invasive surgery? It's all just because of logic, and we're going to talk about the logic that leads us to what we do. One of the things I think you have to remember is that even though we know in surgery we do a really good job, we're still getting our asses kicked. So transcatheter valves are okay, but they're going in everybody. And fortunately in our program, we've been able to keep a finger on the scale. Coronaries, we saw earlier today from Dr. Taggart, 15-1. In the UK, it's 4-1. So what's going on there? So health status after transcatheter versus surgical aortic valve replacement. Even at a year, the people were healthier if they had a TAVR. Why? It's the sternotomy. It's the big incision. You cut the biggest bone in their chest in half and put it back together with baling wire. TAVR, wallop, SAVR, and cost effectiveness. So what's cheaper? A TAVR's cheaper. Because people come back into the hospital, have long-term care issues, have to go to extended care facilities after heart surgery. They don't with transcatheter valves. So those are the things you have to tackle. Pain, strength, mobility, home. People go home, they're satisfied. In aortic valve surgery, we can do a right anterior thoracotomy, we do crowd nerve block, mitral tricuspid surgery, you can do minimally invasive surgery. Everything else, unless you're Gianluca Terragrossa or Sam Bulkey, you're going to do a sternotomy. Coronary surgery is still done through a sternotomy. Don't forget about this website. Go find it. This is a fabulous website put together by some of the folks here on this stage. We publish these guidelines. I had the honor of contributing a little bit to that, that everybody quotes and cites. It's the most cited paper from the journal. So, how do we cut the chains of sternotomy and accelerate recovery? How do we do it in our program? We do preoperative education, minimally invasive approaches where we can. We manage the sternum with rigid fixation on every single human being that gets their bone divided. Minimal opioid use, early mobility in ICU, multidisciplinary teamwork, the things you've already heard about. We do prehab. We are evaluating our patients aggressively before surgery. We're coaching them on what their expectations are while they're in the hospital. We have a very good multidisciplinary team. I have to say our program loves ERAS, so everybody participates. Everybody that touches the patient participates. And everybody participates in this meeting that we have every month, where we run the list on every topic that we cover in our ERAS program. So we've got respiratory therapy, physical therapy, nursing, ICU nurses, administration, pharmacy, everybody is in that meeting. I wanted to get this, which is minimally invasive surgery, for our sternotomy patients. How can we do that? Whoops. So this was actually, I like this slide because it was sent to me by, this is my inkling. This was a patient's son who's watching his 82-year-old father bowl 6 weeks after surgery. I didn't tell him to do that. And he sends me this video, and I thought, well, wait a minute. Maybe we can let people do whatever they want. The elephant in the room, right? The elephant in the room is the fact that we have this bone that we cut in half. And we know that ERAS translates really into getting people back normally and quickly, dependably back to their lives. Wire cerclage is lousy. Okay, I have a whole bunch of slides with lots of papers on wire cerclage, and the reality of it is that people who like to talk about it the most are the people who aren't heart surgeons, because we don't want to talk about it. But there's a nice paper here where they show you all these different ways that you can weave the sternum together, and these radiologists show us all the cool ways that heart surgeons close sterna, and they show us how lousy it is. So this is normal, where you've got a hematoma and a bone that's separated, and this is kind of stuff they see where bones are falling apart. And this is how you fix it. This is not what you want to be known for. This is not like, send it to so-and-so because they can put the bone back together for you, right? You don't want this or this, and you don't want meatus tinnitus. So, rigid plate fixation versus wire cerclage, hands down a winner over and over again. There is nothing that wire cerclage does better than rigid sternal fixation. Everything's better with it. So, what about that? What about after sternotomy? Why don't we let people just do whatever they want? It's because they hurt and because the sternum's going to become unstable, so that we have to get past that. We don't wait for the bone to heal. We put it back together properly. We do an orthopedic repair of the bone, and then we let the people do what they normally do. We're not waiting for the bone to heal. This is an example. This is rigid sternal fixation on steroids, because we also have these fiber tapes. These prevent any cut through on the bone. You can use wire cerclage for approximation of the bone in the vast majority of patients without issue. If you have the opportunity to use something that's broader, that goes around the bone, that won't cut through the bone, notch it, and people with osteoporosis that will pull the bone together without cutting through the bone, then this is a nice way to do it. And so the first thing you have to do is to achieve really good approximation, right? So just like when you use wires, when you use wires, we're kind of vexed by the fact that as we twist them down, we got that last turn and you can snap the wire, and we're trying to figure out how tight to make it. With this system, we get good approximation along the entirety of the bone, so we're going to expedite healing. We're going to have good compression on the bone that is consistent across the entirety of the length of the bone. And you'll see here in a second that we can use tensioners. So this is kind of step one in the process of moving up the scale of putting a bone back together. And these tensioners then allow us to set the tension that we put on the bone to approximate it homogeneously. And we have two tensioners working at one time. Those are figure of eights on the body of the bone and simple in the sternum. So every single patient in our practice gets a full approximation and then gets a full set of plates. And with that, we allow them to resume their normal activity. It's already pretty solid, but not solid enough. So they're going to get a full set of rigid plates. We try to get bicortical purchase, and everybody gets 3 plates. In other words, the entirety of the sternum is plated. You cannot plate just part of the sternum. Pain management is very similar to some things we've already heard, and I'm not going to spend a lot of time dwelling on that because you've already heard it. We do use all the kind of the standard ERS methodology for diminishing, for both addressing pain and diminishing the use needed for narcotics. We essentially don't use narcotics anymore. We do use IV acetaminophen, and there's fentanyl available during the first 8 hours after surgery, but after that they don't have any real access to narcotics because they generally don't need them. We'll give them if they ask for them. Everybody gets out of bed right away. Nobody goes back to bed all day long. So right after surgery, within 4 hours, they're standing at the side of the bed. Within 4 hours of coming out from the operating room, and most of them are extubated in the operating room, and then the next day, they get out of bed and they stay out of bed all day. They're up in the chair. We track our ambulation because you think you're walking people and you find out you're not walking them as much as you think you are. This is just an example of when we went back and looked. We found we weren't doing as good as we should. We got it up a little bit. We used to do this. We had red and green sternal precautions. Now we do this. We don't have sternal precautions. So we just ask people to use both arms. If they want to drive when they leave the hospital, it's fine with me, but they can't have a home nurse then. So if they're going to have a home nurse, because the nurse won't come and see you if you're mobile, I tell them to wait 5 days to drive. Sternotomy narcotic usage, this is what happened. Oops, something strange just happened there. Are they cutting me off because I've gone over? Narcotic usage essentially is gone. We use the equivalent of maybe 3 or 4 5-milligram codeine pills. This is what has happened over the last several years. Pain scores went down at the same time. So at the same time that we took away narcotics, the pain scores went down. So not taking things away and making them suffer more, they are suffering less, and we're taking things away. And so you got a dude like this, post-op day 5, you got to let him use his arms, climb out of bed, move around, do whatever he wants? I don't think so. Not if you just use wire circlage. You do what we do. You let him do what he wants. Or this fellow. Just had a big operation, post-op day 4, he's going home. Can't do that through a little incision, at least I can't. And old people. Old people do not want to be a burden. So if you tell them that they're going to have to be taken care of after heart surgery, they don't want to have heart surgery. But this lady just got, she's three hours post-op, sleeping comfortably on her side. And post-op day 2, putting her through the motion, she's getting ready, she's going to go home, and then she goes back to work in a few weeks. Opioids, like I said, we got to stay away from. The young guys are vulnerable. They hurt more. They're just more vulnerable. People go home. This guy went home day 2. This guy went home day 2. It's easier to get people to quit smoking if they don't hurt, by the way. They're not having pain. It's a little easier to convince them not to smoke. So minimal pain, full mobility. Don't send them to the extended care facility. And just to briefly touch on that, at the same time as we got rid of the narcotics and including not discharging them with narcotics, we saw our incidence of requiring an extended care facility go from 30% down to 8.9%. So discharge to extended care facilities went down, as did readmissions. Which one of these guys had a sternotomy? I think you're going to figure it out from the way I've been bragging. It's that guy. 3 weeks before he had a sternotomy. That's the message, which is all the things I just talked about. Got to manage the sternum, and then start taking advantage of it. When you see the pain go down, you start getting that tube out faster, getting them out of bed, and letting them do what they want to do. Back to life. Thanks.
Thank you. Let's open the floor to questions now. We started a little late, so we can go over a little late if anyone's interested. Questions, anyone? Walk up to a mic, introduce yourself, and please ask it. I'll kick this off with a couple questions I have. First of all, I like the point that was made, I think, by Dr. Reddy, who can join us up here if you'd like, but is that in many of these institutions, they thought certain patients, low risk only, should be in the ERAS protocol. And can anyone really see a reason why every patient shouldn't be in it, and we should sort of opt them out for some reason if they can't be? Can anyone on this panel?
Well, that's what we did.
Yeah.
Our data shows that you can get people through at a much higher rate. Compliance will still be a compliance with some surgeons, so we have to just go back and audit their data and convince them that they're going to be fine. But we did that back in March, and we went from 5% to 80 to 90% some months.
But I get it. But pre-op, sure, you don't want to give them a carb shake maybe and get them, mobilizing because they're, sick as a rat in shock. But post-op, shouldn't everyone follow ERAS best practices for, MCS? They have a VAD-in. Can't we have an ERAS protocol for somebody who's got a new VAD-in? I don't know, or, part of the...
Absolutely. I think we're talking about binary versus, understanding that ERAS is really a collection of best practice, like you mentioned. So it's really about complying with the things that you should be doing for all of those patients and not thinking of ERAS as, if you can't do the entire thing, then you're not an ERAS patient. That's not really what we're describing here.
Anything else that we said today that people think are crazy or could never do at your own institution, or what are we talking about, or show me the data, or wire cerclage works great in my hand, why would we ever possibly go to a mic, why would we ever possibly talk about using a different closure method?
No, Mark, very inspiring. I'm talking about early mobilization after sternotomy. I rigid sternal fixate everybody, and I'm thinking I just need to overcome that bias, educational bias that I come from. I come from the educational bias where this is what they taught me. don't drive for 4 weeks, the airbag explode and explode on your chest. This is, it's true.
had a
I asked
patient
in
do
this
that.
room, this is what everybody got taught from Italy to United States, from Germany to Sweden. That's a reality. Probably we need to shift the way, the mentality, and try, particularly now living in New York and coming in the suburb of the United States, I can tell you that asking grandpa or grandma to do not drive for weeks is a huge diminish in their ability to live their life. It's different that if you are in New York and you have the metro, you have the subway. If you are in just outside of Philadelphia, it's a different game. So I will try it, and if I have one complication, I'll call you. I know your car is gonna explode.
Yeah. As I always say, you know, sometimes people message me or email me or whatever and say they're going to do it. They're going to do rigid fixation. I say, well, then do it right, though. So, and I know you do. You've visited me. We've spent time together. But my point is that if you're going to do it, you do it all the way. Full plating, great approximation. I did have a really big guy who drove from Wisconsin. He got in his car after surgery to drive home. He got in his pickup truck. He was about halfway to Wisconsin. He rolled it, and his bag went off. And I found out about it 6 weeks later because he said, Doc, I was embarrassed. I didn't want to tell you about it. So he just, he went home and he was fine. So,
Oh my God.
Hey, Mark, nice presentation. What's your experiences with using cryo nerve blocks? Anybody has that experience? And
that's
what's the
several years of it. I mean, and
routinely every
we
day?
use it for everybody that we do any type of thoracotomy on. Any
What
type
about
of thoracotomy.
sternotomy?
No, no, because the
That's what I'm saying.
plating is really.
For sternotomy. do
Yeah, I
anybody
know
use
some
it?
people are doing that. I would like to, if you're going to compare things, I think you'd have to compare plated sternum versus sternum with the peristernal cryo, which is what I know people are doing.
How much of post-op pain do you think is micromotion?
Personally, I think it's most of it. I think it's most of it. It's just experiential, though, right? It's it's one of those things that you see it. Once you eliminate the micromotion and the person's not hurting anymore, all I did was put the plates in. So I just submitted a paper that looks at the impact of when we just started plating, when we added our first phase of ERAS, and when we added our second phase of ERAS. And so part of it was what Gianluca was talking about, which was kind of that psychology that we just can't take all this stuff away. We can't let people do whatever they want. But then as we implemented ERAS, ERAS accelerates everything. When you do ERAS, you are putting your foot on the gas of everything that you do. So you start looking for those avenues, those pathways. I think micromotion's a big part of it.
Mark, one other question. What about other adjunctive agents in addition to closure? Osteoblastic stimulation, antibiotics, anything else that you could potentially think of?
Oh, we do use antibiotics in the wound too. We use actually chlorpactin, believe it or not. We do a 3-minute chlorpactin soak at the end of the case once we have the sternum together. But as far as bone closure, bone healing, we kind of don't care about that. I'm just being honest about it. Because if the bone never heals, it doesn't matter because I've already let them do whatever they want. So, eventually the bone's going to heal, and we know that people who have rigid fixation, their bone heals faster. We have that well documented in studies. But we want to make that not consequential. I mean, it'd be great if we could stimulate everybody's bone to heal faster, and I think that would be wonderful. But the added work and cost of that might be prohibitive when we know that we can let them do whatever they want anyway.
Mark, have you looked at any bone cements? There's some products out there now that are.
Yeah, so when that bone cement first came out,
Right.
and Paul Fedak was using it and I know he still is in Canada. This is while I was still in Chicago, so it's about 20 years ago. I did use it, and we stopped when they pulled it off the market, basically. And then now it's back, right. And then I did call Paul to talk to him about doing a comparison. He was more interested in whether they should do both. So I didn't, we didn't go any further with that. But it's super interesting to think that you can just cement the bone back together.
Any other thoughts from the panel here? Anyone want to jump in on any topics that they want to hone in before we end this session? I want to remind the audience that we have another session, part 2 of this, where we get a little deeper into some of these issues and the controversies tomorrow morning at 8 for those early Sunday morning risers in New York City after a big night out Saturday night. So there you go for that. If not, thank you.